Hello, thank you for joining me today at Sister Friends Cups in Conversation. I'm your host, Teresa Cooper, and we're getting ready to have one of the most meaningful conversations this season. You're going to want to stick around, call a girlfriend, a sister friend, and let's get around the table. It's going to bless you, it's going to inform you, and it's going to be good. Let's go. Welcome to Sister Friends Cups in Conversation. I'm your host, Teresa Cooper, and I got my co-host, Miss Catherine.
Always here and always ready.
Yes. So we're glad to be here this afternoon, and we're going to have a great conversation. We have Miss Dawn Collins back at the Sister Friends table.
Hey, thank you so much for having me once again. It's always a good time.
Yes, always a good time when Sister Friends gather.
That's right.
And today we have a new sister friend that we've known for quite a long time, but she's here in her professional capacity.
Yes.
Brandy Ratliff.
Thank you for having me. Good to be here with you
Yes.
ladies
Good
today.
to have you.
Thank you so much again for having me. I'm excited.
Absolutely. So this is going to be, as you can tell, this is going to be a great table. You're going to learn a little bit more about each of our sister friends as we progress the conversation. Before we start, though, I want to, our featured cup. Now, everyone else has our Sister Friends cup. Yes. If you want one, just inbox us, go to the website, and you can get one. But today I want to focus on this featured cup. It was a gift. I don't remember who gave it to me, but the hearts.
Yes.
The hearts. And I thought, we're going to talk about something that's really dear to my heart, and really all of our hearts. We've been impacted in some way or another. And so I thought this would be a great cup for this conversation. Love yourself better, ladies.
Yes.
I'll drink to that. I'm going to give you a
I'll drink to that. I'll drink to that.
Yes. We ready. Oh.
I don't know what you're drinking, but I'm drinking lemon lime water.
I'm drinking ginger ale.
Okay, ginger ale for the burp. What are you drinking, Dawn?
I'm just drinking water.
Water
They don't even have
does
lemon
the body
in it.
good. Water does the body good. And Brandy, what are you drinking?
Just water.
Just water. Hey, we all need more water.
Yes, yes.
Okay, so today we're going to be talking about medical bias. And we're going to be talking about medical bias in, the modern world, in our modern times. We would think that some things we would have evolved from, but unfortunately we have not. Bias and myths still occur in our times. You may have been impacted personally, or you may be have been impacted by someone in your family, your children, a coworker, someone that you know. The lack of global and ethnic diversity can be a leading factor in medical bias and myths. Medical schools are teaching medicine. They're not necessarily teaching history and culture.
Yes.
And so the awareness comes from our environment. The awareness comes from our reading and our self-efficacy. We depend on our doctors to know the medical truths, the medical facts.
Yes.
We just assume that they have that bedside manner and that they are, culturally competent.
Right.
Yes.
And that they are world, minded and world travelers.
That's right.
And that probably could help, not probably, but it does add to whatever medical skill that they have, right?
Yes.
So we're going to talk about that today. And some of you might be saying, well, what kind of conversation is this? This is, table conversation.
Yes.
The stuff we talk about, at least the women I know,
Yes.
talk about in their kitchen, at their dining room tables, and they want to talk about the OBGYN. And girl, they had me in the stirrups for 30 minutes.
Yes.
I had an appointment. Listen, I had that happen.
Yes.
It was over. It was an hour.
Oh, wow.
I got up,
would
got
have
dressed,
Oh, wow.
and said, I will not be back.
Wow.
Because I felt
Good for
so
you.
insulted
Yes.
that you had me just propped up.
I was holding up
And
to
just
you.
waiting. I was like, where the doctor went? Oh, he got called to the I'm like, well, y'all didn't think to tell me.
Oh, yes.
Yeah, so things like that happen.
Yes.
So this is a necessary conversation. This is not going to be medical bashing.
That's right.
That's right.
The bias flows both ways.
Yes.
There's a patient bias towards medical
Yes.
community, medical professionals, and then there's the medical bias from doctors, nurses towards the patient.
Yes.
Today we're going to be talking about toward the patient.
Okay.
We'll have another episode on that. We can't,
Okay.
cure the world all at one sitting.
Yes.
We catching up
Yes.
with that. So I'm going to throw the ball to Brandy. Tell us a little bit about what you do, your profession,
Sure.
and why you have this wonderful white coat on.
Awesome. So my name is Brandy Ratliff. I am a nurse practitioner.
Okay.
I practice normally as a family practitioner covering the ages 0 to 99. I am qualified to treat acute and chronic conditions, and that's what I do every day. That's my passion. The reason I have the white jacket on, it symbolizes professionalism.
Okay.
But it also, you walk in the room and it symbolizes, the diversity between the nurse and the nurse practitioner, the role difference.
Okay.
Yes.
So that is why I have the white jacket on. I would like to have on regular clothes every now and then. It's kind of fun. But that's what I do. I'm a family practice nurse practitioner.
Good. Yes.
Something interesting. My doctor, my family doctor, he decided to be a concierge.
Oh, yes.
Yeah.
Yes.
I guess that's a new thing.
It is.
And I really liked him, and I was a little disappointed. I'm like, he's leaving us. I don't got enough money. My insurance not that good. What are they paying him?
Right.
So I was happy for him. But when it was time to look for another one, I wanted to stay within the same practice, and it turned out that I picked the nurse practitioner,
Okay.
and I thought, I'm going to try something different.
Yes.
She was a female, and in a lot of ways, she was going to be doing exactly what the regular doctor was doing. Can you explain a little bit about that, and even like why you stopped at nurse practitioner, because there's a couple of more years maybe to become a doctor after that, or
Yes,
We just talked
just
about
for
this
those,
earlier.
for people that may not know, because that is a real
Yes.
because there's a shortage in doctors.
Right.
The nurse practitioner is doing some fabulous things and making moves.
Well, I'll start by saying this. Nursing, I've been in nursing almost 20 years. It gives you that bedside aspect and that more personal interaction with the patient.
Yes.
I think we're trained to nurture. All
Okay.
right.
Yes.
Nursing, the nurturing aspect of it. So that allows us, when we branch into a provider, or we're not a physician, but we're a provider. When we branch into a provider role, we still can operate and do certain things that MDs can do. But from a nurturing standpoint, some people, like you said, prefer a nurse practitioner because they can kind of get down to their level, sit down and listen to them, because we were trained bedside.
Okay.
So that gives us, we're
Okay.
trying to sit at the bedside and hold the hands and watch people take their last breath, and even just rub their head when they're sick.
Yes.
So the empathy is a little bit different from an emotional standpoint, because we are trained in school to do that. That is training that we take. Yes, I do think that some people should go on and be physicians. It's about another 4 years. It's a lot more intensive training, a lot more specialty training. I chose the nurse practitioner route because it still gives me the autonomy to do what I want to
Yes.
do and practice what I want to practice. Now, if I could do it over, I probably would go back to med school and start from there. But I'm too old for that now. So we're going to just stick with the nurse practitioner role. But there's still things that I would love to do, and I'm able to do that with the autonomy as a nurse practitioner.
Okay,
Good.
that's wonderful. That's good news to know. And I have to say, my primary care nurse practitioner, she does listen. And you know what I mean? Like, she really spends the time to listen to whatever the concern is. And so that's important.
Yes.
Now, Miss Dawn, tell us a little bit about yourself and what you do and how you are in the medical community.
Okay, well, I am a doula, and a doula is a person that supports a birthing person in the family through their pregnancy, labor, and birth. I am not a medical professional at all as a
Okay.
doula, but because you're in that environment, people can sometimes get that mixed up
Okay.
between a doula and a midwife. A midwife is more like a nurse, and she has the medical knowledge, to be able to help the family, the mother stay well, the baby stay well through all those stages. But as a doula, we just simply support you mentally, physically, emotionally, and spiritually at times. And I love that role.
But let me just say this, but as a doula, you do have to have medical competency.
You should.
Yes.
Because I mean, you know what I'm saying? You're not just there rubbing them and giving them support, but are you not also explaining terminologies and helping them to make...
Yes, ma'am.
Okay.
So, to what you said.
Okay.
As a doula, the support comes in many ways, and the main support that we're known for is education and information, which you were talking about.
Yes.
And we have to constantly say we're not medical professionals
or
even medically competent.
Okay.
We have to keep that separate from our role.
Really?
We do legally. It's the best thing for you to do because you didn't go to school for, like you went to school to do what you did.
Yeah.
We don't go to school. We get training. And the training is not an actual governed school.
Okay.
Like a university or anything of that nature. It's someone who has gone to school to train other doulas. But the training is it's good depending on who you go to. So what I do with my clients, what I explain is the education piece. I explain the steps that they go through when they go to their doctor or their nurse practitioner. If they were to see you and they had their appointment, I would talk to them about that appointment. And what ends up happening is you hear the questions that they didn't feel comfortable asking. You hear the hesitancy in asking the question. You hear the concern for something that they just didn't express in the office. And so then at that point, we pull the information out for them, give them the resources. And I've actually gone as far as giving my clients verbiage. You go back to the doctor, nurse practitioner, and this is how you want to phrase it and say it so that it's not a combative encounter.
Yes.
Like you said earlier, we're not here to bash the medical community at all.
Yes.
We need the medical community. When I get sick, I'm going to see my doctor or the ER.
Yes.
So we need you.
Yeah.
Our role doesn't exclude you. Our role includes you. We are collaborative for this family.
Yeah.
So yes, we do explain the different procedures that they would have, their test, why. We go a little further in the education information because you all don't have time to do that with every one of your patients, even though your heart may desire.
Yeah.
You don't have that time. I sit with my clients anywhere from 2 to 4 hours.
Oh my goodness.
And we go over breastfeeding, for instance. We go over the labor positions. We go over the stages. We go over what your body is actually doing, the biology that's taking place. Because, did you know what was going on with your body when you had your first baby?
No, ma'am.
I know I
did
didn't.
not. I did not.
I didn't either.
I just knew this was going to happen. It was going to hurt.
Right.
Yes.
Yeah.
And I watched too much TV. I watched too much Lifetime.
Right. So what are some of the added things that you offer? Because I thought you also do deal with grief.
I do. Every doula is different. Doula is an umbrella term, so I want to make that clear. So there are end-of-life doulas.
Okay.
Birthing doulas, just that support that you need that's outside of your family. Before I answer that question, I want to say the reason why you should get a doula is because of that support that's outside of your family and your friends. You may be able to tell that doula something that you cannot express to your family because your family loves you, but they might not understand
That's
Okay.
what you're going through.
Yes.
And then you'll say something like, oh, I'm not connecting to the baby, or I feel like this. And your family member might carry that on for the rest of that baby's life. But I am going to help you understand what's going on and get you connected to a therapist, a resource.
Okay.
So that's what a doula does.
Yeah.
But as far as, what was the question again? I'm sorry.
I think you also do deal with grieving, but you highlighted that doulas can have specific
dual roles.
You can have dual roles. It's not effective if you step into all those roles.
Oh, yeah. So you can have a certain concentration, just like a doctor would have.
You can.
Okay.
You can. So I offer, as you mentioned, end of life grief for those that have lost their babies, whether it's pregnancy or miscarriage or stillbirth or some other way that you've lost the baby. I support you during that time because what has happened is once your body releases a pregnancy, a baby, you are then thrown into postpartum, whether that baby is alive or not.
Okay.
And so
Yeah.
there's a whole cycle you need to have support to go through. A lot of folks get thrown back into work right away. You don't need to go to work. If your baby's with you, a lot of times you can take that time off. But when babies are not with them for whatever reason, people expect them to come back to work.
Right. So the doula is there to help advocate for you.
Help you advocate for
yourself.
yourself.
Yes.
Teach
Okay.
you how to do that.
Right.
And
Okay.
then when you can't,
Mm-hmm.
then we step in.
Okay.
And it's not just the birthing person, it is the support team as well, the husband, the partner, the boyfriend, the family members. Because what I tell my clients is, I'm going to leave.
Right.
I'm eventually going to leave, but these people are going to be here for you.
That's great.
So we teach them how to support
Right.
Yeah.
and
Okay.
speak up.
That's good.
Yeah, that's
Yes.
awesome.
That's
Well, as you can see, this is a very informed table here
Very
today,
informed.
Kathy.
Yes.
Yes. And so my next question is to Miss Brandy. What portion represents how many women, or it could either be women or it could be people of color. What's the representation as far, if you know that, as far as the percentage of that are doctors or that are nurse practitioners?
I don't have an accurate percent number for you today, but I will say that we are the minority.
Okay.
I can
Is
say
it
that
somewhere like around maybe 5-6%, or could it be lower?
my study from 2017, it was about 6%.
Okay.
But that's an older study.
Okay.
So there are some more minorities going into medicine, but we're still
Yeah.
not there yet.
Still,
Yeah.
yeah.
We're still not
So
there
it's,
yet.
it's definitely not at 25 or
no,
30
ma'am.
or 40%.
No, ma'am.
Of the
No,
pool.
ma'am.
Well, let me ask you about what we're talking about, which is medical bias.
Sure.
And there's like a little clock that I have, and
Okay.
it just gives you the different the different biases within medicine, within the community. And then I'll just shoot them at you, and then you tell me, your what you want to say about it or your thoughts.
Okay.
So as far as bias, opinions, thoughts, myths, that's basically, background for what a bias is. We could even extend it to maybe an implicit bias,
Yes.
something that people don't really know that they even
Yes.
have.
Yes.
They picked it up through travel, through being
Yes.
raised,
Yes.
family, ideas, what have you, and they don't know that it's instructing their behavior or their opinions or thoughts about people. Geographical location.
So yes, rural areas tend to get less care. So geographical location is definitely a area that is not exposed to as much care as the normal if you were in the city. So rural areas tend to have different types of, medical directors out there, doctors, so there are not as many. So the care is far and few between for those patients that are in different geographical locations, i.e. the rural areas.
Okay.
So access to care is different for those people.
Okay. So we should actually be more, as a community as a whole, should we be advocating for more clinics, more, I don't know about hospitals, but we could probably advocate for more clinics in rural areas.
So yes, and actually areas that are, providers that go out to the rural areas, they are paid on a different pay scale. The rate is a lot higher.
Really?
Yes,
Okay.
yes. The drives, it's in the middle of nowhere most of the time, but those people still need care.
Yeah.
And getting that access to care, you have a physician that's there maybe 3 times a week because they have another job most of the time. But and you have some that are dedicated nurse practitioners, physicians to that rural area. They love those little populations of people and they get great care. But the access is different for the people that are in the rural areas. They have to, transportation issues and just getting to those physicians.
Okay.
So yes, we should be always advocating for more clinics, more providers in those areas, mental health, nurse practitioners, just all the way around that gap. There's a huge gap in care there.
Okay.
I'm seeing a lot of that. When you said that in the smaller towns, if we go out of Shreveport, Bossier, Benton area, you see a lot of clinics popping up different places. Also, I'm noticing a rise in traveling nurses.
Yes.
And that they are going out into these small communities, giving care. And even where I work, like a lot of the ladies, if their kids need, specialty care, you have nurses going to their homes that live on the outskirts of where we live and giving them in-house care. So I thought that was good. So they wouldn't have to travel all the way back in or couldn't get to care.
Yeah.
What are your thoughts on mobile care? Because I know in the birth work world, they're really trying to get mobile care to the rural areas.
I love it. I think that if we could bring care, you know, in medicine, we try to meet the patient where they are.
Yeah.
Yes.
And if that means meeting them where they are with a mobile unit, you're actually meeting them where they are. You bridge them, you put them on that mobile unit, you love on them, you take care of their needs, medically chronic conditions, acute conditions, and they're most likely to trust you when they see you out there and they're, you know, coming out to them, bringing yourself to them. So it makes them a lot less leery getting on and saying, oh, you know. So it's a little more comfortable for them when they come out, when you come to them. So I think that mobile units are it's big in bigger cities, but here in our area it's not as many. I think some of the local FQHCs offer, like David Rains, and I know that
they do.
Yes, they do. And this is some that offer mobile mammograms that I've seen. So I think those are amazing, because any way you can take healthcare to an area that's not getting the healthcare, it just opens up and bridge gaps for people that are not, wouldn't have the access to that care.
Okay,
That's good.
What about sexual identity?
So yes, the sexual identity population, a lot of patients feel that they are actually biased against when they expose or tell you that they are LGBTQ population of people. And that also makes them not want to come and be honest with their provider. I've seen that in the clinic I work in now, but when they feel comfortable talking to you and you sit down and you spend that time with them, they open up and tell you, this is what I'm doing. So you can take care of them the best way. If you don't know what's going on, but you have to make them feel comfortable. You have to let them open up.
That's right.
And be vulnerable to you so you can help them.
Yes.
And so they've been steered away because they felt like, they were judged.
Yes.
Okay.
So it has to be a judgment-free zone. Medicine is judgment-free. We're there to take care of that patient, no matter what situation or circumstance they find themselves in.
Yes.
And so once you establish that with the patient, they open up to you. So that is definitely a huge bias, and breaking that bias is just coming in and being judgmental free.
That's good. Sex and gender.
Sex and gender, the statistics say that women are less likely to get pain medication. African American women of color, when in need. I read that just yesterday. And so, yes, I do believe that is a huge bias. The statistics show, or the stigma is, we can handle the pain.
Right. And I'm like, where do they get that from?
School.
It's in school.
They teach.
They still teach that.
That is what the statistics show. That's what the medical journals show.
Really?
I wasn't taught that in school. I was taught pain is pain.
Right.
You know, whether it's white, black, Mexican, Hispanic, Vietnamese, it doesn't matter the race. Women or men, pain is pain, and what they tell you is their pain. And there are certain markers we look for when we judge a patient's pain. But that is true. That is, if you read articles or you look it up, African American women are least likely to get pain medication even after having procedures in childbirth, which is the most painful situation and circumstances. They're less likely to give us narcotic pain medication.
Right. And then also, when you're talking about pain, I've noticed that in childbirth area, like a lot of the ladies that I see, they go in the hospital, they have no doula to advocate for them. They go to, a hospital where everybody would go, state hospital, and they tell me some of the treatment that they get. It's biased, because I'm like, you lay on the table and almost have a baby by yourself. And if you're telling the doctor, hey, I'm in pain, the baby coming, no, it's not. You just feel that. And it breaks my heart sometimes, because it is a bias. I'm like, were you in pain? And then we finding out, you read in different articles now. And I think since people in high places, family members are dying from childbirth and different things, they putting a light and shining a light on them now.
Yes.
And it's really sad.
So we determined that the sex and gender bias, some of that is connected to the education that they're receiving, or the information that they're receiving while they're in. Is that what we're saying?
In school?
In school, yeah.
I don't think so. I don't think that.
Or is it societal?
I think it's more society. I know I wasn't trained in school.
Okay.
That I think it's maybe a stigma, but I wasn't trained. I don't think any physicians, are trained that African American women or this population of women, whether are trained to handle pain better. You know what I mean? I don't think that we're trained. I just think it's a perception.
Yes.
Okay, yeah.
And it was kind of brought down.
Okay.
Yes.
So what about the bias? Because on this clock, it has education. It has socioeconomic status. So, can the biases show up? Because sometimes they will ask you what's the highest level of your education.
Yes.
And I always thought, what does that matter?
So yes, education. If so, two reasons why we would ask that. I would ask because if I'm giving you a thick booklet about your new diagnosis of hypertension,
That makes sense.
and you have a great reading level of a 4th grade, you're not going to be able to read that.
Yeah.
And if you're embarrassed to tell me that, if I don't have the knowledge to know that, I can't. I'm giving you something you can't do anything with.
That's
so I
good.
can sit down and talk to you and say, low sodium means salt. Look at your label.
That makes sense.
But yes, education. If you do not know, you don't know what to ask either.
Yeah.
So if you don't have the educational background to say, well, they gave me 5 pills and I only understand what 3 actually are for. Education means like knowing what to ask the question, knowing how to advocate for yourself.
Yes, that
because
makes sense.
I feel like if you don't know how to advocate for, you don't have the education to advocate for yourself. Sometimes the ball can get dropped, and that's in anything.
That makes sense.
Yeah, it
That
does.
makes
I'm glad I
sense.
asked that question. Okay, so socioeconomic status. Would they actually treat you better if you had more money or less money? How does that work? Because
I have to be honest.
Yeah,
I do. I think it is a bias because I'm in the medical profession, so I still have to be very gentle with my words.
Yes.
But I have seen, that's why I went back to become a provider, where Medicaid patients or patients that doesn't have insurance are treated different.
Yes.
I have to be honest about that.
That's true.
The Medicaid pay rate is way lower than a private paying patient, or a private insurance patient. So sometimes the care is rushed. Not everybody do it, but sometimes the care is rushed because the Medicaid only gives a certain rate for that window of patient. So the physician is trying to get in and see 20 patients, but they're looking at the rate. You know what I mean? That Medicaid is giving them for that patient. So yes, I do. I have seen that there's a bias. Patients may not get referral sources. I may not get as many testing because they have Medicaid. When you have somebody with Blue Cross or TRICARE, Healthy Blue, these United Healthcare private plans, they would get different referral sources or a more invasive care, if that makes sense.
Okay.
I will say for a birthing woman that is an African American, it doesn't matter. You don't get better care because of that when you're pregnant.
Okay.
You just don't. And
Whether you have good insurance or if you're on Medicaid,
Right.
you're saying it doesn't. And that's a
statistics.
real.
Let me tell you why I can piggyback with
academic,
that. I had a situation just with a family member that gave birth. She was hypertensive, postpartum, very educated, very, very educated, and 160's normal blood pressure. So let me give you this: is anything below 130/80, right? That's what the American Heart Association want the blood pressure to be. Her blood pressure was running 160/90's postpartum. She went to her PCP. They told her to go home and lie down. She went back another time 2 weeks after that. Baby's maybe like a week old, and she went to the ER this time. Well, they gave her some PO medication and sent her back home. Now, in the meantime, I left out the most important thing. She had a major headache. And that was one of her symptoms. My head is killing me, And so when she called me the second time, I said, we're going back to the hospital. I'm going with you. And I'm going to advocate for what I see or what the possibilities could happen. But she had been sent home. So she has private insurance and she's educated. But they still sent her, she's African-American female. They'll still send her back home. And, when they did, we got to see the imaging and things that was required, and that we made them put on a drip. The things that was required or needed, the quality of care, the standard care that should have been given, right?
Okay. Yeah.
Let's put it like that: the standard of care that we are using, guidelines. In medicine, there's guidelines, and we are supposed to follow those guidelines to protect the patient. So, with that being said, we got her in the hospital. She had her blood pressure down, but what could have happened if she went home? And statistically, 60% of African Americans, the mortality rate is high. It's 2.5 more than white Caucasian.
Right, but if they don't know that, if they're working and practicing their medicine, but they're not up to date with the latest stats or the news about that, you know what I mean?
Yes, ma'am.
Then they'll easily just continue to do what would happen to your family member.
Yes.
But do you think the hospital could play a part in that? The certain hospitals or places of care that they go to? Like, I won't go to certain hospitals in the town because I've heard things about it. So I'm gonna go. So do you think that plays a part as well?
I can't say. I think it's a lack of education culturally around
Okay,
that, because
that's good.
no matter what hospital you go to, you're going to have some culturally deficient people
Okay.
that
Yeah.
just don't understand how to reach a different culture.
That's okay.
Because they outside of their work, they're not interacting
Right.
with other groups of people.
Not always.
And so sometimes it's what happens away from work that also informs
Yes.
our work.
Yes.
You know,
Yes.
and this little time clock is I'm not even all the way around, because we got social economic status and then ableism.
So ableism is like disabled.
Okay.
So for patients that are disabled, they tend to get less care, or they
Okay.
tend to their needs. For statistics, I don't practice this way, but statistically shows that they are kind of shoved to the side, or they're
Wow.
not getting the proper referral sources, or even the magnitude of level of care that someone that can speak and talk properly. So yes, I do.
Yeah.
So I mean,
Yeah.
even with autism, you look at the diagnosis of autism, and they have to fight for everything they get. So yes, there is a difference
Okay.
in
So
bias there.
then the last three are age, overweight and obesity, and then racial bias. So those are that ends out our clock.
Okay.
But those are all biases that at any given time that somebody might be facing. Age, where people maybe ignore youth.
Yes.
Versus, and they could be having a real medical condition,
Yeah.
but because they're young, no, that won't happen to you. And they're saying now that more and more younger men are getting prostate cancer,
Yes.
and so nothing's an exact science.
Right.
Yes.
To play the devil's advocate, we've all heard people say, because we talk about bias and implicit bias, and people say, well, we're all human. We all bleed, red. That's true, but then it's only true on the surface.
Right.
Because not every individual and not every people group is the same. They do have different medical markers
Yes,
and different things
That's
that
right.
we have to pay attention
That's right.
to
That's right.
based on, their ethnicity.
Yes.
And it
Oh,
doesn't have
yes.
anything, it don't have to be racism.
Yes.
But it's knowing that the world is filled with beautiful, diverse
Yes.
people.
That's the word. That's it right there.
And so let me, how can people better advocate for themselves? I'll ask each of you that question, and just give us your best, advocacy. How could they advocate better?
I want to add two more people to that clock, but I want to ask you
Okay.
a question too. Which one you
Yes.
want me to do first?
Let's add two more people.
Okay. Substance abuse disorder.
Oh.
Patients that are abuse substances, and I see this every day, and it's so sad. They are ignored.
Okay.
They are biased against,
Yes.
and they're judged.
Yes.
And guess what they do? They don't go back.
Yes.
So when they come to you, they've been without care for 10 years
That's sad.
because they battled their addiction, and nobody wanted to hear what they had to say. They still had chronic conditions that needed to be managed, even though they were battling their addictions. So they're judging those people.
Yes.
Mental health patients, again,
Okay.
that's my other second group, other last clock people. Because they're mentally challenged, yes, it's going to be a little bit, the care is not going to be cookie cutter. They're not going to do everything you tell them to do, because the mental health may be not where it needs to be.
Right.
But they still need an advocate. They still need you to treat those other chronic conditions and listen to them.
Yeah.
So those people are often biased against as well. They're judged to me, and I feel like they need a voice. They need someone to listen to them and say, hey, I may not have broke this addiction, but my blood pressure is still so high.
Yes.
I need you to get this. I'm still
Yes.
fighting with this, but help me with my blood pressure. And guess what? A lot of times when they see that you care, they comply with what you ask them to do.
Wow.
So, and mental health as well. I'm still battling my bipolar or schizophrenia, and I may not take my medication there, or I may not, but my diabetes is 10. My A1C is not where it needs to be. I'm going to sit down, and providers, we should sit down and talk to those patients and get the mental health people involved, and don't ignore they have it, but treat them as they are, as you would treat anyone else. It's not cookie cutter, but you will give them a little more attention because they may not understand.
Yeah.
So the time may be different. You can't go in and rush in and out with those patients. So they are often biased against. I just want to add that little
Yeah,
tad
well,
bit.
thank you. As you can see, this table is not just informative, but they're very passionate.
Yes.
And so we thank you for your passion for what it is that you do. Now I'm going to give them an opportunity to leave the best practice that you can have for advocacy for yourself. We're going to do that at the Something to Sip On segment of this show. But I want to just challenge you, pray for your medical providers. Pray for those that are out there, the traveling nurses. Pray for those, the doulas, the nurse practitioners, and the doctors. They're human.
That's right.
Yes.
You know, and so they're serving and they're doing what they're called to do, but they're also doing it in their humanity. So I would just challenge all of us to pray for your specific provider, but then to pray for our medical community as a whole, and that they'll continue to educate themselves, they'll continue to rise to the challenges, and that they'll do it with passion and with compassion and with care. So thank you for sharing this time with us at Sister Friends Cups and Conversations. Thank you for joining us today at Sister Friends Cups and Conversation. This was a great conversation, a great table conversation with Sister Friends. Be sure to continue the conversation and share this across all of your social media platforms. Meet me next week, same time, same place, new Sister Friends. This is Something to Sip On. Now that was a conversation, ladies. And I want to say you are your best advocate. And I'm going to just pass this baton and let these ladies tell you how to best advocate for yourself moving forward. Kathy?
I would say education, education, education. What you don't know can hurt you. And you could go to someone you trust and just ask questions. Google is out there. You could ask questions on there. It's different information everywhere. But before you go to your doctor, know something.
Oh, yes, that's good. Know something. Miss Brandy, what's the best advocacy?
Advocacy, I think, find someone that you're comfortable with sitting down and talking to them. Because if they understand you and they sit down and listen to you, they're going to help you get the best care that you need. So advocacy, educate yourself, like Pastor Catherine said. Educate yourself, and then talk to your provider and be open and honest with them. Don't be afraid to do that. Thank you.
All
That's
right.
good.
Now, Miss Dawn, you have the last word.
Okay, well, I would say everything these ladies said, because education is actually key.
Yes.
It's actually key. Now, how you get that education, yes, you can Google, you can talk to folks, but you have to just sift through it for yourself and what feels right for you, okay? And then on top of that, if you feel like you don't have anybody, don't forget to pray.
Yes.
You know, pray while you're doing this searching for this information. Pray over your doctors who you choose. Just pray.
I love that. Prayer works, and we're praying to a God that responds.
Yes.
He don't just listen, but he responds.
Yeah.
So take this, and this is your Something to Sip On for this week. God bless.
Bless you.